All right, I'm back. And so I recently completed the series on Chapter 11, which deals with controlling microbes in the environment and involves using chemicals and physical approaches uh, to reduce the load of microbes that could potentially um, uh, lead to pathogenicity, lead to infection, and or cause spoilage of food and other problems. So um, now we turn to what happens if you do get an infection. And the focus here is primarily going to be on bacterial infection. I don't have anything planned as yet relative to other kinds of infections, but just to give you a good feel for some of the different approaches that can be used for dealing with bacterial infections. Um, let's go ahead and pull up the PowerPoint. All right. So this is from Tallaro and Chess's chapter 12. Um, drugs, microbes, host, the elements of chemotherapy. So we refer to this as chemotherapy anytime we use chemicals to control pathogens, microbes that are present in our bodies that are causing infection. Now that doesn't necessarily mean disease is is present. You don't have to actually have symptoms, although that's typically when you would seek chemotherapy to try to deal with that. But yeah, infection is anytime they take up residence in your body and begin then to flourish. Ultimately, there may be some symptoms that arise, and that's when we would treat. So the chemicals that we frequently use in dealing with bacteria are antibiotics, right? And these, as we'll point out later, are products of microbial fermentation themselves. These are chemicals that they use in antibiosis, or it's sometimes called allelopathy. They're chemicals that they use to defend their own spaces, their own territories. All right, so they're the weapons that microbes use, and we in turn have learned how to exploit those and use them for our purposes in chemotherapy. So when you have an antibiotic, and some of these things would apply if we were talking about antivirals or antifungals as well. But when we're dealing with antibiotics to treat bacterial infections, these are the properties that we're going to want to try to place a premium on and ensure that they're optimized. They're made as um, optimal as possible. We want selective toxicity. Now, when we were talking about physical and chemical agents of control, dealing with microbes in the environment, one of the things that we would want to emphasize there is broad spectrum effects. So if you use a cleaner on a countertop, you want to kill everything. Um, Here it's a little different. When we're applying an antibiotic, um, we know what the infection is being caused by. We know that organism. I would hope that that's the case. You don't want to just randomly go shooting in the dark and hope for the best. So we can determine what the organism is that's causing the infection. And we want to select a drug, an antibiotic that will deal with that, and that alone, hopefully. That's probably wishing for too much, but as selective as we can get it, all right? Because if we have this peripheral damage, we're hitting other forms but only sort of indirectly, we're not really taking them all out. Ultimately, we could promote antibiotic resistance in other organisms, other infectious organisms. So we want, and the other thing too is we want to apply things, we want to use antibiotics that aren't going to harm the host. All right. So that would be the sick person. We want selection there as well. We want to hit the infectious agent and do as little harm to the host as possible. So we want to choose antibiotics that will target prokaryotic cells and components of prokaryotic cells as opposed to eukaryotic cells. That would be great. We could do that. We want these things, here the operative word is kill, so we want them to kill these organisms. We want them to be microbicidal. See the root side in here? When you see that, that means kill. We don't want them to be microbistatic, right? We don't want to achieve some sort of stasis with these organisms, that is, knock them back to a certain point and then allow them to continue to live, but at a lower population count. We don't want that. We want them all gone, right? If we can help it. And and that ties in with selective toxicity as well. If you kill them all, then there's no survivors. There's no chance then that they can adapt and evolve toward resistance. So that's going to be helpful in that way as well. Another thing is when we introduce them into body fluids, whether that's into muscle, or we put them directly into the bloodstream, or whatever context they're being taken up, across the mucosa of the small intestine, they need to be able to make entry into those places and remain active, even though they're encountering these different chemical environments in the body. That stands to reason there. We want to use things that are effective in small concentrations. All right, so what would you rather take? A pill the size of one that we would give to a horse, or something the size of an aspirin tablet? All right, that's kind of probably overstating it a little bit, but yeah, you want to be able to have things that are effective in smaller concentrations, so that we don't have to overload the body with all kinds of things that really don't belong there. The smaller concentrations would be what we would want to emphasize. And there's this term that we use in referring to these drugs and their effectiveness. We talk about half-life. So the half-life of a drug is the amount of time that it would take for it to be reduced to half of its original amount, either through elimination or metabolism of the host. So it's if certain dosage is injected or ingested, a certain dosage is applied, the half-life would be the length of time that it would take for half of that to be basically diffused and made incapable of fighting infection. So we want to increase rather this half-life. We want it to be fairly long. We don't want for people to metabolize or secrete this away very rapidly. Otherwise, it's just not going to have its desired effect. All right, and when you want it to get to the site of infection, you inject it, it needs to be able to get there, and so on. We want it to be cost effective, reasonably priced. If somebody is having to pay $1,000 a day for their chemotherapy drugs, their antibiotics, that may not be, efficacious. That may not be something that they're capable of doing. So we want to keep it cost effective. And then, all of these other things tie in with keeping the host healthy as possible, even though they're infected. We want to introduce drugs that don't add to their woes. We don't want to pile on. And so some things are potentially allergenic. We want to make the determination whether or not they're allergic to it. If it's something they're allergic to, we don't want to introduce that. Unless it was, say, a drug of last resort, it was the only thing we had available. That would be a real problem there. But we don't want it to be allergenic. We would hope that the normal flora, which we're finding is incredibly important to our function, that is all of the organisms that are present that are mutualists with us, or at least commensals, the hundreds, maybe thousands of things in your gut and on your skin and elsewhere. We want to leave that as intact as possible. We want to keep that community flourishing so that they can do the services that they do for us. One of those would be to prevent the entry of infectious agents. So if we kill that flora off, other things can come in to infect besides that which we're currently dealing with. So we want to keep that defense up. The other thing too is if we're destroying parts of the normal flora, some of those things that are there are held in check. If we begin to kill off certain members of the flora, something like C. diff, Clostridium difficile, could come out of hiding and become more abundant and cause infection. It can also lead to evolution of resistant forms, right? We're killing some of these normal flora members, and we don't kill them all. We leave behind some survivors. If they're potentially pathogenic, we've got a bigger problem on our hands. So we don't want to harm that normal flora. And generally, with antibiotics, you are going to do some of that. So when antibiotics are being chosen, when they're being investigated, if one can determine that they're really capable of sort of targeting in a specific way particular pathogens, hey, that's great. That's what we want to try to emphasize. So that's what we're looking for. All right, and we want it to be of low toxicity. These so again, that ties back in with keeping the infected person as healthy as possible. We don't want the drug to be damaging to them. All right, so some of this has been redundant, but these are all points that are worthy and worth repeating. All right, so anyway, there's all of that. So there's a bunch of different terms that get thrown around, and there's certainly misapplication of some of them. But chemicals that are used to control microbes in the body are referred to as antimicrobials. These chemotherapeutic agents, that's another term for them. And if something is regarded as an antibiotic, right, if we use that term antibiotic, it is specifically referring to something that is of all natural origin. That is, it's been produced by some other organism. And typically that would be fungi and bacteria. These are things that they're making. They're fermenting chemicals, sugars and various things that they use for nutrition. And then they, in turn, are metabolizing those and releasing them into the surroundings. That's what they do. And so when we find organisms that do this, we can investigate the chemicals that they're producing and determine whether or not they are useful as chemotherapeutic agents. And the search is on for that as we speak. The companies that market these drugs are actively searching for antibiotics. Maybe not as intensively as they should, but I think recent events have kind of spurred them into action. Let's hope. But there are certainly organisms out there that haven't been heavily studied yet that are producing some of these chemicals. And if we can find those and we can figure out how to rear them in a laboratory setting in large enough numbers to produce enough of these chemicals to be marketable, that would be awesome, because those new antibiotics have never been seen by most pathogens. And so, brand new weapon that we can use. Of course, ultimately, those are going to become less effective through evolution. It's kind of like an arms race. It's kind of like we're at war with these organisms. You know, we get a little better. We find a new approach. Well, they evolve in response to that. Then we've got to get a better approach, and then they evolve in response to that. So it's continually this back and forth. We're dealing with biology. We're dealing with living things. So it stands to reason that that's going to be the case. I think humans get lulled into this notion that, well, we're at such a high level intellectually and technologically and so on, we should be able to just make these problems go away. Well, that's not going to happen. So we have to do our best to try to limit the impact that these things are going to have. So there are drugs now. Since the advent of antibiotics, one thing that can be done in a laboratory that is not, solely the purview of organisms themselves is we can take these naturally produced things and then chemically add functional groups to them and modify them to make them more specific for particular infectious agents. And so those kinds of drugs are called semi-synthetics. They're halfway natural and they're halfway artificial, right? So they're modified antibiotics. You can take a penicillin or a cephalosporin or erythromycin or any number of these real antibiotics and tag little things onto them chemically, modify them a little bit. And that's an active area of research too, because that's going to make novel things that organisms haven't already seen, and maybe will help to buy us some time in our struggle with these organisms, these infectious bacteria. And then there are synthetics, and this is a mistake here. So let's erase that now. I don't know if that's something I put in there or if that was in there originally, but I noticed that chloramphenicol was named as a synthetic drug, and it is not. It is actually a real antibiotic. But there are some synthetic things that are solely produced in the laboratory that are antimicrobials, but we wouldn't call them antibiotics. That makes sense. Antibiotic is reserved for all natural. And of course, we've already mentioned this, that these drugs, regardless of what kind they are, they can be broad versus narrow spectrum, and this is what we want. Okay? We want something that's narrow spectrum. We want always to emphasize that. There are a few folks who have had really profound infections in the past who are, suspected of being prone to possible future infections that are given what are called prophylactics. Well, prophylactic sort of dose of antibiotic will be something that a person would take essentially in small amounts every day to basically prevent them from becoming infected again. And I guess some of those drugs might be considered broad spectrum. I don't know, that's a controversial practice. Also, prophylaxis might be something someone would do, say, prior to going in for some surgery, like some maxillofacial or oral surgery. A dentist might give the person antibiotics before they go in for their surgery. just to kind of reduce the level of microbes there that could enter into the, you know, the open mucosa that's going to arise during the course of that infection or during the course of that surgery. It's another use of prophylactic types of drugs. Um, I guess maybe those might be considered broad spectrum, but narrow spectrum antimicrobials are generally what we're seeking. We want to know what we're dealing with and have something that targets that specifically. All right, so antibiotics, as I've said, are metabolic products of microbes, and they haven't, of course, been around in the forms that we use them uh, forever. It goes back to 1928. That's when the discovery of penicillin was made by this guy here. This is Alexander Fleming, who was a Scottish microbiologist. And you can see here he's got a bunch of petri dishes in his lab, and he was working with a bacterium. I think it was Staph aureus actually, and growing it up in different conditions and seeing how it responded and all of that, doing some experiments with it. And one day he looked at a plate of the bacteria and he noticed that there was some mold growing on it. And generally, I think people would look at that and say, well, it's a contaminant. That plate is compromised. I'm going to go ahead and autoclave that and get rid of it. But Fleming hung on to it. And what he noticed was that around that little patch of mold, the bacteria were starting to basically die. You know, it left a clear space that actually got larger as time went on. And he deduced that that fungus, which it turns out was penicillium, a species of penicillium, I think it was Grisia fulvin, but that's neither here nor there. He noticed that sort of antagonism between the mold and the bacterium, and deduced that, hey, this mold is producing a chemical that's going into the surroundings. I think it's a chemical that's going into the surroundings that's killing this bacterium, which was known to be an infectious bacterium. Staph aureus was well known as an infectious agent. He thought, maybe we can use that chemical, figure out a way to get that chemical and use that to kill infectious agents. That was in 1928. It was more than a decade later before they had developed the methods for growing up the mold and extracting the penicillin drug, the antibiotic, and putting it into a form where it was able to be administered to patients. And it just so happened that coincided with World War II. So at the beginning of World War II, they were using another drug, which is purely synthetic, sulfa drugs, which are pretty effective, but this gave them another weapon in their arsenal. And by the end of World War II, there were soldiers that had been wounded who were being treated with penicillin who were recovering from infections that normally would have really threatened their lives. And so the word was out, and thereafter, of course, the rest of the story. Penicillin became considered sort of a wonder drug, and people would take it anytime they got sick with anything. And of course, there were probably many people who were getting things like the common cold, a rhinovirus infection, and other viral infections, and they were thinking, okay, well, the penicillin worked on my staph infection or my strep throat or whatever. Why not take it for these other things? So the lay public who aren't scientifically literate, would be expected probably to think in those terms. And even some doctors, I think, didn't really fully understand that these don't work against viruses, right? So you're not going to take an antibiotic like azithromycin or any number of other antibiotics and expect them to work against viral infections. It's just not going to happen. And so, of course, we've had people recently promoting the use of some antibiotic substances for that purpose, and it's very misguided. But anyway, yeah, so penicillium, and of course later the mold Cephalosporium, which is related to penicillium, was discovered to produce its own antibiotic substance, and thus was discovered cephalosporin. So penicillins and cephalosporins, and then bacteria like streptomyces. Hey, we've got streptomycin, right? And bacillus species produce their own antibiotics as well. So we've got a bunch of things now that are being used as antibiotic substances. In fact, the bulk of antimicrobials are antibiotics. And the bulk of those actually are products of those two genera right there. Bulk of the antibiotics, maybe 70 or more percent, come from the genera Penicillium and Cephalosporium. All right, so we can thank Alexander Fleming for that. He made some other discoveries too that were pretty profound, like the discovery of lysozyme, which is in your tears and saliva, and I think even in breast milk, and it has antimicrobial properties. Anyway, yeah. So here's some of the genera of organisms of microbes, both eukaryotic and prokaryotic, that produce these substances. Right? Some of the very common antibiotics that many of you have heard of and have taken for infections, or some of you have even administered these, I'm sure. So, yeah, bacitracin and polymyxin from the Bacillus species. You can see the names of the drugs are often some related to the forms from which they're taken, like streptomycin from Streptomyces species of bacteria. We'll look at these: erythromycin, tetracycline, vancomycin, chloramphenicol. Now, this is the one earlier that I had in that PowerPoint slide listed as a synthetic. I don't know how that happened, but that's actually a natural product of fermentation of some of these Streptomyces species. These are some of them really very potent chemicals that unfortunately do have effects on folks who take them as well. So, but anyway, you've got a rich arsenal, and of course we need to add to it to deal with the problem of antibiotic resistance. All right, so as was done previously when we were talking about physical and chemical agents that control microbes in the environment, I said you could brainstorm all of the vulnerabilities of organisms and come up with sites that you can attack, and then find the chemicals or the physical agents that would fit those roles. Well, we can do the same thing with these antimicrobial substances. And you can see some of the targets are pretty much the same, like the cell wall, which is probably of all of these things the best one to hit, because bacterial cell walls are very different from the envelopes of our own cells, the cell membranes. We don't have cell walls, for one, and we certainly don't have peptidoglycan, which is the main component of those cell walls. We don't have that either. So if we can target the prokaryotic cell wall, we're going to do relatively little harm to ourselves when we take those drugs. And you can see the list of drugs, and I'm not going to belabor that. I'm not going to have you learn all of those, but you can see clearly here at the top The penicillins and the cephalosporins are listed at the head of the pack. Those are well-known cell wall inhibitors. They actually inhibit the synthesis of it. So you take those, hopefully early on in the infection. That's going to shut the organisms down. They don't have an active cell wall. If they can't produce that, they're not going to be viable, and so the infection will be stopped in its tracks fairly early on. Now, if you got a bunch of already formed bacteria that already have their cell walls in place, generally those cell wall inhibitors aren't going to do much to those. It'll prevent the infection from going forward, but you just have to wait for whatever infection you have currently to clear as a result of that. So hitting it early, striking early in the lag phase or early on in the exponential phase of increase of the population would be best. So if you can't target the cell wall, well, let's go to the cell membrane. It's super important too. That's basically the entry point that regulates what comes and goes, and so you can target that, or you can go to internal sites within the cell and begin to target those. So nucleic acids, you disrupt those, you disrupt replication, transcription, and translation. That's vital for any organism to keep those things going. They can't keep those going, they're not going to be able to metabolize, they're not going to be able to maintain homeostasis. That's it, they're going to die. Right? So you can see there are a number of drugs that are utilized for that purpose. And then you've got protein synthesis inhibition. So proteins, including enzymes, are needed for metabolism. So if you can shut down the synthesis of those, you shut down an organism. And so if you think about all of the metabolic machinery needed to make proteins, those are all points of vulnerability. So ribosomes, here we've got the prokaryotic ribosome, the 70S ribosome. We can target different parts of that. So there's a 50 and a 30S subunit in there. You can target those either individually, or you could target them both together. Either way, you're going to shut that ribosome down, and that's going to stop translation, the actual synthesis of proteins, the making of proteins. You don't make those, and the organism can't then have enzymes it needs for metabolism. It can't have the structural proteins that it needs for other purposes. So blocking that. Now, you might think, well, that's a great one because, hey, we've got 80S ribosomes. That's not going to harm us. Well, what do we have in our cells that does have 70S ribosomes? We've got little prokaryotes that now are obligate organelles in our cells. They are the mitochondria. Mitochondria, as I've said repeatedly, are in fact obligate members of our ensemble of organelles that are bacteria, right? Eukaryotes took them up early on in their evolution, and they've remained with us ever since. That's where they live. They live in our cells. So if we take these drugs, we're going to kill bacteria, sure. Some infectious agent that's doing us harm, we're going to kill that, but we're also going to do damage to our own mitochondria. So some of these drugs are kind of toxic, right? It's always the case with chemotherapies of any kind, or whether we're talking about taking out bacterial cells or taking out cancer cells. The patient is going to have some sort of negative adverse effects as a result of that. So we want to reduce that as much as we can. Chloramphenicol, I know, is really bad. My daughter has a horse that had a grievous injury, got caught in some barbed wire and nearly cut some tendons and other things. And it was touch and go. We didn't know if the horse was going to make it. And they administered chloramphenicol, and we had to be really careful in giving the horse chloramphenicol that we didn't get it on our skin, because this will actually disrupt hemopoiesis. It will shut down the production of new red blood cells and other blood cells, I'm assuming, in the red bone marrow. And so you could wind up with leukemias as a result of this, anemias as a result of this. That could be fatal. So it's really very toxic stuff. And I think they administer that only when it's absolutely necessary, when somebody is likely going to die anyway without being given something. So they may survive the infection and come away with some residual problems that they might have for forever after, because of the chloramphenicol or other very dangerous antibiotic that they've taken. So not all of them are, going to be, completely devoid of negative symptoms, negative consequences. And then another way to go is to actually target the metabolic pathway. So to target enzymes that are already active, if you can target those and shut them down, you'll shut off metabolic pathways that are needed by the organism. So say they take in some substance and they metabolize that to make, a vitamin that they need, or some other coenzyme. If you can disrupt that, and if you can find a metabolic pathway that they have that the infected person doesn't have, that makes it all the better. So that's another vulnerability, the metabolic pathways. And so we'll look at examples of those. Now, these drugs that are listed here for that, these are actually synthetic drugs that are antimicrobials, but they are not, strictly speaking, antibiotics. All right, but those can be used as well. All right, so yeah, we've already beat this one into the ground. Hopefully, narrow spectrum and broad spectrum, those terms make sense to you now. So review that. Okay, so let's look at this. A drug that targets lipopolysaccharides, that would be the LPS, in the outer membrane of a gram-negative cell. If it targets just those, what would we consider that? Would that be broad spectrum, narrow spectrum, selectively toxic? Then you got those combinations of those. And the answer should be E, narrow spectrum and selectively toxic. That's what we're going with there. All right, because it's only going to target prokaryotic cells, all right, lipopolysaccharides and outer membranes of cell walls are found only in bacteria. And of the bacteria that it targets, it's going to be a specific category, the gram-negative forms, right? And so it's narrow spectrum and it's pretty selectively toxic. It's not going to harm the host. It's not going to harm the infected individual, at least not all that much. All right, so I'm going to stop this there, let you digest that material, and I'll do another lecture and put it up. I'm going to do this in chunks. And so it'll be maybe 3 or 4 lectures on this. All right? I'm going to stop it right there and put up another lecture here shortly.